Hello everyone, I am Dr. Uthra. I am a consultant diabetologist practicing in Chennai. I am here today to discuss a case scenario in the early intensification or using combination therapy which can offer equal or better tolerability and additive glycemic efficacy on comparison to metformin monotherapy. For that, I have with me a case of Mrs. M, a 52-year-old female. She was started on metformin and lifestyle modification when she was diagnosed 9 months ago. And in the first 3 months, her HbA1c decreased from 8.7% on diagnosis to 8%. She lost almost around 6 kgs weight with her intensive lifestyle modification. Her follow-up visit at 6 months showed a HbA1c 7.6%. She further lost 2 more kgs of weight, and the metformin at that visit was increased to get optimal control. Now she is back today with us after about 9 months of diagnosis of diabetes. She does not have other comorbidities like hypertension or dyslipidemia. She has hypothyroidism, for which she is on levothyroxine 100 micrograms QD, and she is also on metformin 1000 milligram BID, so 2 grams per day. On the social history aspect, she lives independently. She is a widower and she lives alone, and she also has a strict exercise regime of 1 hour workout 5 to 6 days a week. Now the current presentation from the lab value showed an A1C 8.1% compared HbA1c of 9.8% 3 months ago. Her EGFR was 88. LDL, HDL, triglycerides were 80, 34 and 150 respectively, and TSH was 1.7. Her LFT, ECG, mitral proteinuria were all under normal limit. On physical examination, she had a BMI of 32 kg per meter squared, which according to the Asian Indian phenotype is morbid obese, even though she had lost somewhere around 8 kg in the past 6 to 7 months. Her blood pressure was 120/70, heart rate was 85 beats per minute. So this is a perfect example of why intensification of treatment should not be delayed for patients with type 2 diabetic mellitus who are not meeting the treatment goals. So Mrs. M also feels guilty that she's not able to do it with all the lifestyle intensification she's been doing. So very well we here know that this is not because she hasn't been able to do it with lifestyle. It is a case of clinical inertia. So you have to think of an early initiation of combination therapy to achieve glycemic goals much earlier, to postpone the therapeutic clinical inertia, to delay the deterioration of glycemic control, and also to potentially preserve the beta cell function. So in the naive type 2 diabetic or the newly diagnosed type 2 diabetic, in which group of naive or type newly diagnosed would we consider a dual therapy? You can think of an early initiation of combination therapy if the A1C level is above 1.5% above the glycemic target. So for example, if you take Mrs. M, we have set a glycemic target in concordance with the ADA or the AAC guideline as less than 6.5%. At first visit itself, she had well above 6.5. So when you put it as 1.5%, anything above 8%, you have to think of a combination therapy even on diagnosis of diabetes. So what is the rationale behind the combination therapy is that we know diabetes is a multifactorial, multipathogenic disorder. So when we use combination, we are addressing multiple metabolic defects. And diabetes is also a chronic progressive disorder. Thereby, we have to be advanced and progressive in our treatment protocol too. Limited efficacy of single drug should also be considered, and the potential to preserve beta cells and the lack of durable response with initial monotherapy should not be forgotten. Now, by using a combination therapy, we are not only lowering the HbA1c much earlier, but we are also lowering the risk of microvascular complication, because the legacy effect can have a lot of negative impact on the prognosis of outcome of diabetes. And you have to hit the target hard and pretty early to break the glucotoxicity, because we know that hyperglycemia begets hyperglycemia. There are enough evidence to support the same. Even the trials from the ADOPT trial did show the decreasing durability of diabetes. The medication failure at about 5 years of monotherapy was 15% with rosiglitazone, 21% with metformin, and 34% with glibenclamide. This does not mean that Mrs. M failed in treating a disease. It just shows a case of clinical inertia or therapeutic inertia due to the biggest barrier of diabetes management, that is hypoglycemia and weight gain. Now, because of these two huge barriers of optimal control, there is significant proportion of population who remain poorly controlled glycemia in India. So, even a recent retrospective cohort study showed that on an average in patients with HbA1c of above 7%, it took almost 3 years for the physician or the endocrinologist to increase the treatment from 1 OHA to 2 OHA. So almost 3 years hyperglycemic period was there. So the exposure of time in hyperglycemia is pretty high. Now the early glycemic control leads to better outcome, including reduction in the long-term macrovascular and microvascular complication. So for patients who are inadequately controlled with metformin, you should definitely think of a combination therapy, maybe as a single pill, as a combination, as a dual drug or a triple drug combination with or without metformin according to the need. This will help in bringing down the pill burden, the compliance will improve, and the clinical inertia would be avoided. So when metformin is not suitable, you can even think of EMPA or LENA as an alternative first line therapy. So remember, if the A1C level is above 1.5% higher than the target you have set for the patient, definitely you can think of a combination therapy at the first visit, on diagnosis or first visit per se. So even according to the ADA guideline, the treatment goals involves not just bringing down the numbers or the glucocentric approach, but also addressing the CV risk factor management. So we are looking at a more patient-centered approach to diabetes care. Now the choice of a pharmacological agent from the armamentarium should consider the account of comorbidities in addition to the risk of hypoglycemia, impact on weight, the cost factor, the potential for side effects in the particular patient, and also the patient preferences. There are enough evidences, clinical evidences, which shows that SGLT2 inhibitor and DPP4 inhibitors in combination is an effective option for management of type 2 diabetes mellitus, and it also provides an HbA1c reduction, a robust reduction of almost around 1.5% to 1.1%, along with an additional benefit of weight reduction of 2 to 3 kg when added on with metformin, which is its primary place in therapy. Now this combination also promises the benefit of cardiovascular positivity. There are enough data from the EMPA-REG and so on which showed that the positive efficacy data on empagliflozin is consistent cardiovascular safety. And the DPP4 inhibitors, on the other hand, have a neutral effect on the ASCVD when added to the standard care. There are also other studies which showed that phase 3 randomized trial investigation which showed that this combination, the empagliflozin and linagliptin combination was even better tolerated when used separately as monotherapy. So there were subjects who were put on EMPA and LENA combination of 25 and 5 milligram and compared with those on empagliflozin 25 milligram alone. So what happened in terms of the serious AEs? There was a reduction of almost around 4.4 versus 7.1% in the combination arm compared to the monotherapy, and the hypoglycemia was 3.6 versus 3.5, and interestingly the genital infection, the most common side effects we incur in the SGLT2 inhibitor group, was 2.2 versus 8.5%. Now these facts all put together implies the fact that EMPA or LENA as an add-on to metformin combination constitute equal or even better tolerability than even monotherapy, and also has an additive glycemic efficacy in all uncontrolled type 2 diabetic patients. Thank you.